So the question posed to me is, should these second and third line agents be moved up front? Now that we have so many different lines of therapy and so many options, I think how to use them to the best of our ability is a very good question. And I think nobody can deny that we've come a very long way from our rhubarb and orange peel days, where maybe it wasn't as satisfying to treat myeloma, but when all you had was 1 or 2 drugs, it was certainly a lot easier. Even up to 50 years ago, you had melphalan and steroids. You could use them together. You could use a small dose or a big dose, but those were really the only decisions to be made. I think with the turn of the century and that first wave of what are now called the novel agents, that started a tide that I think even fellows in training now don't realize how paradigm changing that was, because we've now come so far. So a word on myeloma, I think every year, if you follow the SEER database, we are having an increased incidence of cases and a slight drop in the death rate. But in 2016, we're still projected to have over 30,000 new cases of myeloma with over 12,000 deaths. So this is certainly still an area that requires a lot of our attention. So what have we seen so far? The first of maybe the big novel agents was the lenalidomide. So we were still able to do placebo-controlled studies back then. And we saw that lenalidomide is better than placebo in the relapse setting. But I'll point out, we were still looking at months as in our axis. In time, we were able to look at newly diagnosed patients. And now we've broadened it over to years. So the conversation started changing as far as overall survival for our patients. Similarly with the proteasome inhibitors, the first one that we had, we first got data on the relapse setting and then moved it up front with, again, even better outcomes. Even with long-term follow-up, newly diagnosed patients do better than relapse patients. Again, not a big newsflash. In time, it got harder for us to do these single drug studies or to have placebo-controlled studies. So the data starts getting a little murky because we're doing a lot of combinations to the benefit of our patients, but the detriment of the clean data. Similarly, again, with the second wave started coming up, we do have a few more studies with only Dex as a sort of a co-member. With daratumumab, I think the most recent single agent data and maybe the last that we'll see for a while. But again, in the heavily pretreated, starting in very advanced disease and not yet up to the newly diagnosed. The DEXAMETHASONE was another on my list of things to address. And again, all the data that we have is in the relapse setting and is in combination with other partners. With carfilzomib, we have a little more information. We have single agent data, we have combination data, we have relapse setting and frontline, which we just got to see. But when we start getting graphs that look like this, although it's what we as physicians and researchers seek to do in our business, it starts getting really hard to improve upon. So we no longer really look at overall survival as our metric, but I think nobody's surprised to know drugs do work better earlier in the disease course. So that's one argument. Well, what about responses? Everything that we do is aimed at an overall survival benefit, but we just saw that we really can't aim for that because by the time that data comes out, it would be sorely out of date. So we've started using progression-free survival. Is that a safe surrogate? Do the two really correlate? Maybe, maybe not, but it might be the best that we have so far. We're making so many gains that the PFS is now starting to get too high, and we've already heard this morning that by the time we wait for PFS data, that would be out of date as well. So can we really use response as a surrogate? We have drugs that have been so far approved based on response data alone. So does response equal survival? Most of the data that we have comes from the autologous transplant data, and we have a number of studies, both prospective and retrospective, looking at responses and effect on survival outcomes. While I think most responses do correlate with an EFS or a PFS benefit, the data on overall survival is still a little bit murky. some conflicting data looking at very similar patient populations, and just not that clear linear progression that we would like to see to make us feel comfortable. So this is from way back in the good old days in 2006 when the IMWG came out with the new uniform criteria. And we had, in addition to this complete response, what we could now call a stringent complete response. We had a new blood test. We could go deeper. And wasn't that nice? Of course, we've come a very long way in the last 10 years. And our ability to detect the presence of myeloma has gotten much, much better, and not in a linear way. We've had different groups really develop and perfect different methodologies to evaluate for the presence of the disease. And the IMWG sort of listed out to us how to compare and contrast different ways of evaluating MRD. And in the newest regimen, so the newest IMWG criteria, even the title changed. It's no longer just the response criteria, but it specifically addresses minimal residual disease assessment as well. So I think the goal would be for the sustained MRD negative state, and maybe if we decide there's a cutoff that would define, potentially start using the word cure in myeloma as we sort of have enough numbers of patients falling into that category. In the meantime, we have immunophenotypic and molecular and other names for the completeness of our remissions based on how you evaluate it. I may not be able to tell you anything else. So I will keep talking and hope the slides catch up to me. So the idea being that what is complete is really a moving target. I think you've all seen, imagine the next slide is the iceberg. We've seen you have myeloma present. Oh, thank you. Whew, I don't know how many I could get through. So the disease burden is really when you see what you can detect on blood tests, which, you know, it's wonderful to have a blood tumor marker. It's really just that tip of the iceberg. Getting what we used to consider a complete response before 2006 is now a meaningless data point. What a complete remission means sort of is being adjusted every time we have better technologies and deeper abilities to detect. We mentioned this morning, 10 to the minus fifth seems like a reasonable place in 2016. I can't wait till 2026 when someone looks back and says, I can't believe they used to think that was okay. So I think the depth of response is still a moving target. So what is complete is yet to be defined. And lastly, quantity versus quality. When we're talking about these responses, not only do we want complete responses, but we need to take into account the whole picture, and now we can. So who is the patient? We've just heard a great talk on how age and frailty and comorbidities can help guide our treatment. So maybe in a 40-year-old who is otherwise healthy and in a 93-year-old who has 17 medications for all their other health issues, your approach is going to be different. Your goal of depth of response is going to be different. What about disease? We continue to redefine risk stratification, but I think we've all had patients who are very classically deletion 17, 414, high risk, who do very well for years, and other patients who have no high-risk features that we've yet been able to identify who relapse with extramedullary disease in their first year. So actually defining a usable risk stratification, I think, is an ongoing goal for us. And how did you attain your remission? I think this is one of the big debates that still roams large, is a CR by any method equivalent? So is a CR with chemotherapy alone as good as a CR after a transplant, after an allogeneic transplant? Are we able to detect that difference in depth beyond that 10 to the minus 5? And lastly, how long do you keep your response? So we're all comfortable with doing blood tests and monitoring our patients, but once we have a large proportion of our patients attaining that MRD negativity, when do we look for the loss of MRD negativity? And how will we react to that if we do indeed document that they've now lost MRD negativity? Again, back in the first wave of novel agents, Once you'd had your first remission and you relapsed after, be it consecutive or sequential use of the two biggest guns that we had, survival was pretty dismal. So we started looking at PFS2, which I will not go into more in depth, but I think PFS and overall survival are covering too great of a space and spanning too great a space. So as we think of these surrogate endpoints, can we use response to predict PFS, and does that actually help with the overall survival being our ultimate goal? Maybe we need to add PFS2 or PFS3, because it's very hard to look at data of any induction regimen of the ones we've heard of if you're going to salvage everybody. That magical number of median progression-free survival may never be reached, or overall survival rather, because you keep salvaging your patients. We've all learned to love and accept this graph. I think we've been indoctrinated to think that you will get your first remission will be your deepest and best, and subsequent remissions will not be as deep, but I'm not sure that is going to hold on and continue to be the truth as we evolve with more. But let's say your first remission is in fact going to be your best remission. Then of course, yes, the second and third line agents should all be moved forward. They work better, you're going to get excellent responses. The depth of that response is still, something to be sought. And if that first remission is going to be your best remission, by all means, use the best drugs available up front, get into that first remission, get your sustained MRD negativity, and let's start talking about curing patients. So simple, but maybe not. Keep in mind that drugs are evaluated in the relapse setting first for a reason. We have to prove that these drugs are as powerful and successful as they are in patients who don't have so many already proven evidence-based fantastic induction options. And the studies that we have very specifically look at these populations of highest need, which used to be those patients who've progressed after their first IMID and after their first proteasome inhibitor. So the data is patients who relapse on those drugs can be salvaged. Has anybody looked at the other way around? Is anybody going to fund a study to look at it the other way around? So many questions. And lastly, number of remissions versus depth of remissions. I have a number of patients who are on their 7th, 8th, 12th, 15th line of therapy for their myeloma, and they don't really care if I can get them into a CR at that point. If I can get them into any kind of disease stability with a quality of life until the next clinical trial opens, and that buys them a few more months, I think having serial acceptable responses may be just as good as having that super, super deep response. So who are these second and third novel agents that we're talking about? I would say pomalidomide and carfilzomib was the second wave, rapidly followed by panobinostat, DEXAMETHASONE, daratumumab, elotuzumab in very, very rapid succession. So I'm just going to run through the indications to put it in your mind. Pomalidomide, very specifically in patients who'd had prior lenalidomide and proteasome inhibitor. Carfilzomib, as I mentioned, multiple different approvals, either by itself or with Dex or with lenalidomide and dexamethasone, all in the relapse setting. Panobinostat, again, only in combination with bortezomib and Dex, only in the relapse setting. DEXAMETHASONE, only with lenalidomide and dexamethasone for patients who'd had at least one prior therapy. Daratumumab, this one is approved as monotherapy, but in patients who'd had multiple prior lines or were refractory to both a proteasome inhibitor and an IMID. And lastly, elotuzumab, which again, relapse setting in conjunction with lenalidomide and dexamethasone. So with so many options, every time you look around, a new drug is popping up, there's a new approval, there's a new colored ad in the Lancet or in Blood. Most of my local physicians can't keep track of what's approved for what, how were they used, what order to put them in. And let's not forget, we still have the oldies but goodies who not, as we've heard in myeloma, with the evolution of clones, you can bring back and you can repartner. We have other drugs that don't get used so much. Even the old alkylators As Cytoxin made a comeback in the previous talk, melphalan's still very much a big part of what we do. So how do we put all of these together? It's literally enough to make your head spin. I think that is about a 4-hour talk, maybe the whole topic for next year's conference. So I think instead of answers, maybe I have more questions than really a satisfying end to it. So how do we sequence all of these options? Is there a best way? Is there a sequence that will optimize the depth of response as well as the duration? And how do you combine them? I think very few of us really are comfortable using single agents or doublets. Triplets have definitely sort of made it to the top of the list. And we used to think 4 drugs might be too toxic. But what about 3 drugs and a monoclonal antibody? These are non-overlapping toxicities and maybe a new way to attack this disease. Also, when do you modify therapy? Is a disease plateau? We used to tolerate those very well because we didn't have that many more things to get to. Do we evaluate for MRD negativity? And how do we pick the right patient for the right regimen? I think it'd be very nice to be able to a priori evaluate a patient and say, this is going to be the best path for you. And what are the markers of risk? I think this is, again, a very active area that needs to be better defined. And how do we define response? Are we all going to commit to a uniform way of defining minimal residual disease? Will one technique outwin the others? And the data gets muddy, right? It's hard to inform on the contribution of any single agent when most of our studies to the benefit of our patients are really combination studies. And as we have multiple successive salvage therapies, how do we evaluate that response to their induction? And lastly, the level of detectable disease, which I think I've gone in fairly deeply. So moving forward, I think we're on the verge of gaining ever more insight into the pathophysiology of myeloma. I look forward to a day where we have subtypes and it's not myeloma and the lymphomas. We're also going to identify the different subtypes that should be approached differently. The development of biomarkers, I think, is again a very active area of development right now, and in the next few years should probably come into mainstream and affect the way we treat our patients, and leading to increasingly rational designs. I think in oncology in general, as Dr. Anderson mentioned this morning, we have drugs that act in exactly opposite ways, and yet they synergize and give us even better clinical outcomes. We can't always explain in a test tube what we're seeing in our patients or vice versa. And hopefully using all of this, work towards really personalizing therapy in this era of precision medicine and tailoring therapy to each patient. So Linus Pauling once said, I'm sure you've all heard, the best way to have a good idea is to have lots of ideas, and I think this field is really ripe with that right now. And so I invite all of you to what I am sure is going to be an amazing next chapter in myeloma research and therapy and caring for our patients. So should second and third line agents be used up front? I think that's a very good question. Thank you.